going to go ahead and start with hemodynamic monitoring next. Again, if you get to go to CVICU as part of your clinicals, you most likely will see this hemodynamic monitoring. Most of the patients who come back from cardiac surgery typically have what's called a pulmonary artery catheter, or you may hear it called a SWAN. Swan-Ganz was the individuals that patented this pulmonary artery catheter, and it is used for basically measuring pressures within the heart. It can also be used for measuring CVP and can be used for measuring cardiac output. So it is a pretty invasive type process. The big things that I want you to look at today: what's the purpose of hemodynamic monitoring, identify the indications for hemodynamic monitoring, and identify the components of a pulmonary artery catheter. And that is spelled wrong. There's no, it's supposed to be a T in there. It's just one Ganz type thing. Identify the correct pressure waveforms. Identify the components of the invasive hemodynamic monitoring: the right atrium, which is CVP, the PA pressure, the PA mean pressure, and the pulmonary capillary wedge pressure, and then systemic arterial pressures. More of you will see the systemic arterial lines than you will actually see a SWAN line. SWANs have kind of come and gone out of vogue. Back when I was working CCUs many years ago, they used them quite extensively. They have found that basically with good observation, good nursing care, and good physical assessment, that we can tell about as much about the patient as we need to without having to do that invasive SWAN line. So in CCU, you see them rarely now. Again, most of the time you're going to see them in patients who are coming back from heart surgery and patients who are in septic shock or sepsis. That's where you're going to see a lot of these type SWAN lines, so we can monitor what's going on with them. Some terms you need to know, and you should know these already. We've covered these as our preload, afterload, cardiac output, cardiac index, central venous pressure, pulmonary artery pressure, and pulmonary capillary wedge pressure, or you may hear it called pulmonary artery wedge pressure or just a wedge pressure. It depends on who you're talking to. Phlebostatic axis is very... Yes, ma'am. I'd have to go back and look and see. I don't remember which chapter it's in. A lot of this is not in the book, because the book skims over it lightly. So there's not a whole lot in your book on this. It will talk a little bit about the phlebostatic axis and talk a little bit about the monitoring. It will have some of the values, but as far as the actual looking at the SWAN line, they don't have a whole lot on that in there. So a lot of this is just going to come from lecture. Okay? Mixed venous oxygen saturation, or SVO2, you may see if you're dealing with a patient that is in sepsis. We'll look at that. A transducer, a distal port, a proximal port, a cordis, systemic vascular resistance, or you'll hear SVR, pulmonary vascular resistance, or PVR. Arterial lines, and an ART line is what you'll hear it called most often. Of course, systemic blood pressure, you all know about that. And then normal catheter placed in the radial artery. Look at those. So let's kind of look at what we're going to start out with is looking at this ART line. Okay, and the ART line basically is designed for measuring blood pressure. Measuring blood pressure. It is a more precise way of measuring blood pressure than doing a blood pressure cuff. What happens is there's a catheter, looks just like a 18 gauge IV catheter, and it's typically placed in the radial artery. Now it can be in the brachial or it can be in the femoral type areas, but typically you're going to see it in the radial artery. Now what kind of problems can you see if you're actually putting a catheter into the artery in that area? Bleeding? Absolutely, bleeding. Infection? Yes, absolutely. Say it again. Absolutely, that's one of the bigger problems, is obstruction of blood flow. Because you do have it there, you can actually cause a change in the blood flow distal to that area. So if I have a art line in the radial artery here, okay, so where do I need to be checking circulation? I need to be checking distal to that. I need to be checking my capillary refill, the warmth, the temperature, and everything of the hand. Same thing if I've got in the femoral area, I need to be checking distal to that, looking at the circulation for those areas. Have y'all heard about the Allen's test? You know about Allen's test? I got one yes. Okay. If you haven't heard about the Allen's test, who doesn't know about Allen's test? Sorry if you don't. Okay. All right. Who would like to come help me demonstrate the Allen's test? It's real easy. Come on. Put your hair. That's really all an Allen's test is. But you will see the anesthesiologist, the nurse anesthetist, those people who are putting in these art lines, you'll typically see them check an Allen's test. Respiratory therapy, when they're drawing just a in and out blood gas, if they're drawing radial, they'll do that as well. So that's very important to check that circulation as you're going through. So what are some of the indications of an arterial line? Continuous monitoring of the blood pressure. Someone that's in shock, whether it be hemodynamic, whether it be volemic shock, cardiogenic shock, neurogenic shock, septic shock. We want to monitor that blood pressure very closely. We want to do that. Again, it's very, very accurate. If I have someone that's on strong vasoactive drugs, such as Levophed, neosynephrine, dopamine, many times I want to have a very accurate reading of their blood pressure, so an art line will be put in place. If we have someone in hypertensive crisis and we're having to use a lot of medications to bring that blood pressure down, again, I need to know accurately what's going on. If I'm using the nipride or I'm using some of the labetalol, those type of things to lower that blood pressure, I need to know accurately. I need to know minute by minute what that blood pressure is. So it's very, very important. The other good thing it's used for is if I have a patient on a ventilator, I'm trying to wean that patient from the ventilator, and I'm having to frequently check blood gases, I can draw my blood gases straight from that arterial line. And by getting from there, I'm preventing a stick. Anyone in here ever had a blood gas drawn on them? Thank goodness for you guys. Somebody said they did? It hurts, doesn't it? You can imagine, you know how bad an IV hurts. You're actually going right in there, and you're actually going into an artery. And it is very painful getting those blood gases. And if I'm having to continuously stick to get a blood gas, it's very, very traumatic on that patient, okay? And every time I stick, I run the risk of doing an injury, going through that artery, severing that artery. So by putting in a arterial line, I can continuously draw my blood gases from there. I can do frequent blood draws for other type of things from there as well. So it's really good for those. So contraindications for a arterial line, if there's peripheral vascular disease, there's some type of peripheral vascular disease in those areas, you definitely don't want to put one in. There's some sort of hemorrhagic disorder going on with this patient. We don't want to put that in because the risk of bleeding is too great. If this patient is on anticoagulants, you've got to weigh the risk versus the benefits of that patient. Same thing if they're on thrombolytics. If I've given somebody TPA for a cardiac, I probably don't want to, right after doing that TPA, put in an arterial line on that person because the risks are too bad. You need to look at that insertion site. What kind of problems can there? If there's an active infection going on in that area, I definitely don't want to stick a needle through that and maybe transfer that down into the artery. If there's synthetic grafts in the areas, I don't want to do an arterial line there. Or if there's an area of prior vascular surgery, I don't want to stick in those areas. So those are some of the contraindications for using an arterial line. Your care, basically, again, you're not going to be putting these arterial lines in. You're going to be setting up the system before they put the art line in. You're going to be maintaining that art line after it's put in, and you're going to be monitoring it. So we're going to be checking that dressing. Typically, they're going to put a large, clear, transparent dressing over the area so that you can see it. Many times, if it's put in the OR, they'll actually suture them in place. Now, if they're put in on the unit, many times they won't suture them in place. But if they're put in the OR, a lot of times they'll have little wings on them, and they'll suture them in place. If we're trying to get a good blood pressure reading, we typically want to try to immobilize that site, because the patient's moving the wrist up and down, doing these type of things, it can cause a change in that blood pressure reading in the waveforms. So you may have to immobilize that site. And you want to monitor that site every hour. You're looking for that distal circulation. You're making sure all your connections are tight, making sure there's no bleeding from those areas. This is kind of what it's going to look like for you when you have a patient with an arterial line. You can see here's the arterial line. See the transparent dressing, and they've actually taped the tubing so that it looks different. And I didn't bring a piece of tubing with me. The tubing for these lines, for the arterial lines and the tubings for the pulmonary artery catheter lines, are not normal IV type tubing. They're very hard, they're very thick. They're designed to transfer pressure, because when I'm measuring the blood pressure, I'm basically seeing it works on hydraulic principles. Basically, I'm seeing a transfer of that pulse from there through this fluid back up to a transducer, and that transducer's then allowing that to be transferred into an electrical signal I can read. But that tubing has to be in place. Typically on an arterial line, there is a three-way stopcock right down near the line. There's typically a connection, an extension set that goes from the catheter to the stopcock. That stopcock is there so that I can actually draw blood. That's where I'll draw blood. When we do the hemodynamic, what am I trying to say? Next week in the afternoon, I'll actually have the lab set up, and you can come in groups, and I'll actually show you how to draw the blood from those areas and everything. But basically, there's certain steps you'll go through. You can see they put a board behind this one to kind of keep it steady, so it's there. There are connections here and connections back up going up to the transducer, and I'll show you in a minute. You always have to make sure that stopcock is turned to the right direction. You want to make sure it's turned off to the actual drawing port. If you basically turn that stopcock back toward the patient, and that would actually allow blood to come from that arterial line and come out. So if you left that open in the wrong direction, that patient could bleed out from that. I actually went into a room and got there in time. Someone had left the stopcock open at the transducer site. The blood had backed up from the art line all the way back up, was at the transducer and beginning to come out at the stopcock near the transducer. They just didn't get it pushed all the way over. So luckily, I happened to walk in at the right time for that patient. But those are things you have to be aware of. I want to go over it and just show you. This is kind of what the site looks like when you look at it. You basically have a solution, typically normal saline. Some areas will actually use heparin, but most have gotten away from using a low concentration heparin drip and just use saline. There is a pressure bag that's over that bag of saline. Typically it's 250 or 500 milliliter bag of saline. And one of the things you want to make sure you do as you're setting up this set is you want to get all of the air out of that bag. The video that I have loaded for you shows a gentleman actually setting up one of these sets, and he talks about getting the air out of the set. I think he does a very good job at setting up one of these. There's a drip chamber, and different facilities want different things. He talks about leaving that chamber so you can actually see the fluid coming out. One of the units I worked in did not want any air in that chamber because they didn't want any chance of any air getting into the pulmonary artery or to the art lines. So they actually did not have that. This is pressurized tubing that comes down and goes all the way down to the transducer. A transducer is basically a device that basically is an interface between the fluid and the electrical system. That transducer converts those pulses, that mechanical energy coming from those pulses to electrical impulses that the monitor now reads. And through that, I can measure blood pressure. And that's exactly all it is measuring pressures. I can measure systolic, diastolic, and mean arterial pressures on these patients. Again, through that transducer, you also have a little flush, a stopcock here, and you have a flush device. Because once I draw blood from there, I've got to flush the system through, so it's an area that allows me. This pressure bag is very important. Why is that pressure bag important? Why do I need to pressurize this system? Okay, let's think about it. Say again. He's absolutely right. Because that catheter is in the artery, okay, if I don't have pressure on my fluid greater than the pressure, the blood pressure, which way is the blood going to go? It's going to come out. So I've got to keep that pressure higher in that bag than my blood pressure is. These bags are typically pumped up to 300 millimeters of mercury. And these bags do lose air, so you have to, part of your routine rounds and checking on these sites is to check to make sure your pressure is still at 300 in the bag. And as that bag basically loses fluid, you've got to pump it up again to keep that pressure up. Now typically this bag is going to run at about 3 milliliters an hour. Just enough solution to keep that line open. Okay. That's about all it's going to do. Again, when I first started working, we used heparin in those, but again, most places now have just gone to saline. So it's all a closed system, and we want to make sure it stays a closed system. When we get in there, I'll kind of show you how it's all set up. I have all the things set up. I have an art line set up. I'll show you what the waveforms look like. But it's pretty a neat thing. I do hope that each of you get a chance to work with an arterial line sometime this semester. I think it's something that you need to know. Now, when we're doing, let me back up because I missed. Here are some of the complications of using systemic arterial pressuring. Thrombus, we can always get a thrombus around that area. Blood loss, we talked about. You can get an air embolism. That's why it's so important to get all that air out of that bag. So important not to leave the stopcocks, and make sure you know which way you're turning those stopcocks, so you're not letting blood out or air into the system. Of course, you can always get a systemic infection, which we talked about. You can get arterial spasms, which can affect your blood pressure and affect that distal circulation. You can get hematomas at the area, and you can get inaccurate pressure readings if you don't have the system set up correctly. And we'll talk about heights to set it up, phlebostatic axis, measuring the height, those type things. We'll talk about some of those as we go along. But those are some of the complications. Any questions on what we've covered so far? Again, I do hope each one of you get a chance to do that. This is hooked up to the bedside monitor, and on that bedside monitor you will have a waveform that is showing up. And this basically is kind of what the waveform looks like. You measure the systolic pressure here at the very top of the waveform. Now, all the monitors now have digital readouts, so you're going to be able to see the digital readout of what the pressures are. It'll show you what the systolic is, it'll show you what the diastolic is, and it'll show you what the mean pressure is. But you also need to watch this waveform, because you can get what's called dampening of the waveforms, and that means your blood pressure is inaccurate. You should have a nice waveform that looks very much like this. You basically should go to the top, and then basically at the systolic peak is what they're talking about here. That's where the systolic pressure is. Then it begins to drop down, and you have this dichrotic notch. This dichrotic notch is actually the closing of the valves. So that's what you're seeing there. And then it goes all the way down, and then here basically is where you're going to measure your systolic pressure or diastolic pressure. So systolic at the top, diastolic at the bottom. So you're watching this waveform to make sure you've got a good waveform as you're doing those, as you're monitoring. This just shows what you might see on a monitor. You can see the EKG strip at the top, and then you can see the you can see across the bottom the waveform from the arterial line. Now you notice that basically here's your electrical activity, and actually delayed is your mechanical activity. Remember, we talked about that you can have electrical activity without having mechanical activity. Well, here you're actually seeing the electrical relation to the mechanical activity. Any questions on the arterial line? So what are some of the reasons we use an arterial line? What are some of the reasons we use an arterial line? Blood pressure. In shock patients, we want to make sure we're measuring it carefully in that. Drugs, okay, when we're using the drugs. And hypertensive crisis. Prevent frequent sticks. Very good. That's why we'll use those. Now the Swan scans are the pulmonary artery catheter. This is a pulmonary artery catheter, or Swan scans catheter. Depends on which company you're looking at. This one's produced by Edwards, and this is actually a Swan Gans brand name, okay? And this one's called a VIP because of the ports it has on it. What you're going to need to know is what each of these ports do, okay? And it's pretty simple, okay? I promise you it's not that hard to know what each of these ports do. The harder part is interpreting the data that you get from these ports, okay? So these were developed 30, 35 years ago. I can remember when I first started working, they were actually just beginning to get started. And I mean, it took a lot of learning curve for us to get there with these because it was brand new and we had never seen these before. I started out working in a small community hospital. We didn't do them. We didn't have the physicians, the internists to do those. Anybody that needed a Swans came to Huntsville. So we weren't able to do that. It was really initially developed to help manage an MI patient, to see how we were doing with the cardiac output, how much cardiac output was lost, how was the ejection fracture, what was the pressures within the right atrium, those type things. But now almost no MI patient is going to get a Swan Gans. Only if they're looking like they're going into cardiogenic shock will a cardiac patient actually get a Swan Gans catheter. Now you see it more in CVICU, and you'll see it in patients that we really need. You might see it in STICU, where we've got to manage a lot of drugs, and you may see it in patients who are in sepsis. But that's typically where your only place you're going to see these. Because really what we found out, the risk of using these does not outweigh the benefits of using these. And that through good assessment of that patient, we can get the data we need without using these. Here are the current indications. Any deficit or loss of cardiac function, such as an acute MI, CHF, or cardiomyopathy. Again, as I said, the majority of your acute MI patients are not going to get one of these. All types of shock, cardiogenic, neurogenic, or anaphylactic, or septic shock. I need antiseptic there. If we really need to monitor the fluids on a patient, you're seeing a move, though, away from actually using these to just monitoring central venous pressures. But if you want more information, a lot of times they'll use these, especially our patients who have massive trauma and we're trying to manage the hemorrhaging, patients with severe GI bleeds. A lot of the severe burn patients may see a Swan until we can get that going. And a little bit later this semester, Ms. Lee will be talking about fluid management of the burn patient, which is quite intense. Again, we look at this for early detection, identification, and treatment, threatening conditions such as heart failure, cardiac tamponade, response to the drugs. Are we increasing that SVR, decreasing that PVR, decreasing the SVR? We'll look at that. The other good thing is we can measure cardiac output, a direct measurement of the cardiac output from this. So if we need to know and are monitoring the cardiac output, we can do those type of things. This is all you can get. These are the values you can get from this one little catheter, okay? you can measure a central venous pressure. Central venous pressure is going to be measured through the blue port. The end of this port actually lays in the right atrium, and that's where you get your CVP reading from. Your pulmonary artery pressure. Pulmonary artery pressure is measured through the yellow port. The yellow port actually ends right at the very end. It's the distal tip of this portion. That is where we actually measure the pulmonary artery pressure, and we also measure the pulmonary artery capillary wedge pressure. Same port. There's a different way to measure them, and we'll talk about that more. You can also measure cardiac output. And to measure cardiac output, you basically measure the temperature gradient. We actually will shoot in fluids through this blue port, and then basically we will measure the machine actually measures the change in the temperature from there down to the thermistor, which is right at the end of it, which is the thermometer, little metal tip right at the end here. So what we're looking at is the change, and how quickly that temperature changes will tell us how fast the blood is doing, and the computer will calculate cardiac output. Now, when I first started it, we had to do a whole bunch of equations to do our cardiac output. I love the new computers. You just push it in, push the stuff, and it gives you your cardiac output. So that is the good thing. You can also measure SVO2. SVO2 really looks at how the body is using the oxygen. Is it using the oxygen that's out there properly, or do we need more oxygen? Is it, it really looks at those things. Again, I'm not going to get a lot into SVO2 because that really gets into the big critical care, but just know you can measure that. Other things that we'll look at will be cardiac index. Of course, we know cardiac index is cardiac output divided by body mass index. Am I going to ask you to calculate a cardiac index? No. Guess what? The computer will do all that for you. You don't have to do that. Yes, ma'am. You actually push the fluid through the blue port. CVP is the blue port. We can actually measure. I'm sorry, did somebody have another question? Yellow port measures the PA and the PA pressure and the pulmonary artery capillary wedge pressure. We're going to go. Actually, I got more slides on that. Okay, so we're going to go more specific into that. I promise you. We're going to go on. We're going to cover some. What questions you have, I have it covered. Okay. These are some of the other things we can measure. Pulmonary vascular resistance, which tells us basically how difficult it is to get the blood through the lungs. We can measure the systemic vascular resistance, which is the mean arterial pressure minus the CVP times 80 divided by the cardiac output. And that doesn't mean anything to you right now. If you get in the units and start working with some of these drugs, it'll make more sense to you, I promise. Her question is, do you need to know any of those formulas? I'll get back with you on that. Okay? I haven't decided yet. Okay? This all works because the cardiovascular system is a closed system. You guys understand that it is a closed system. I am not taking this catheter and going directly into the left ventricle and measuring pressures within the left ventricle. Okay? This actually goes through, you can see it goes through the subclavian or the internal jugular, goes into the right atrium through the right ventricle, and then goes out into the pulmonary artery. This is basically right in. Now, remember those pulmonary arteries connect here with the arterial system at the capillary beds, okay? So, in a true hydraulic type system, pressures here should be the same as the pressures here. And that's what we're looking at. We're measuring this pressure here and interpolating that the pressure over here is the same as the pressure over here. So we're not directly measuring pressures within the left ventricle or the left atrium. We are actually using basically mathematics, if you would, to actually measure those pressures using some different types of formulas. You don't have to learn any of those formulas. You just need to understand that we're measuring those pressures indirectly, not directly. And you'll kind of see as we go through those. We talked about this, okay? Did this print out in your notes? Yes. All right, so I've got to go look. I've got to see where, because this should have printed out, because I put up the actual PowerPoints in one of the sections. So I'll go look at that, and then I'll get back to you. This basically talks about exactly what we were talking about, the different ports. Now, this thing does have a balloon on the end of it. This one doesn't because it is ruptured already. But that balloon becomes very important as we're doing some of our measuring. But the balloon basically is what helps float it through. So let's go through the ports again, okay? The blue port. Blue port is the arterial. Let me go through. I think I've got it here, okay? Normally has 3 to 4 ports, okay? One connection in pigtail. When I talk pigtail, this is what I'm talking about. This is the pigtail. This actually plugs in to your monitor and actually measures your patient's core temperature. It's just, and I'll pass this around for you minutes. It measures the temperature. That's what the pigtail is, okay? The blue port, or the proximal port, used to measure central venous pressure. And you can see the blue port here. When we go into the demonstrations, I will actually push fluid through it, and you can see where it comes out on the catheter, okay? The white port typically is just an infusion port, okay? The white port is like for giving medications. If I need to give fluids or I need to give medications directly into the central system, the white port is for doing that. This one is a VIP. It actually has a second infusion port, okay? And it's gray in color. It just depends on which one you have, okay? The yellow port is the major one. This is the one we use for measuring the pulmonary artery pressure and for measuring the pulmonary artery capillary wedge pressure. The red port is basically for inflating and deflating the balloon. That is all the red port is for. The red port comes with a special syringe that can only be drawn back to 1.5 cubic centimeters, or in this case it is cubic centimeters because I'm measuring air. So it only goes 1.5 cc's. That's the maximum amount of air that you will put in the balloon. When I'm measuring wedge pressure, I will blow the balloon up. Okay. And then when I'm finished measuring wedge pressure, I take the air back out. So the balloon is used for 2 things: to help move the catheter into place, and then for measuring wedge pressures. Okay. Yeah. This kind of goes, yes ma'am. The blue port, again, we talked about measure right arterial pressure, or CVP, okay? Normal value of CVP is 1 to 8 millimeters of mercury, okay? CVP 1 to 8. You do need to know your ranges. An elevated CVP can occur with right ventricular heart failure. Right ventricular heart failure. You can see a decrease in the CVP with hypovolemia. Those are some of the major things. There's some valve type changes that will cause these to go up. But really right now what I want you to understand is CVP typically means right failure, and a low CVP means hypovolemia. Are we okay with that? Okay. We talked about the infusion ports, the white port, used for fluids, medications, and many times you'll see most of your vasoactive medications are going to be given through that port. The distal port is the yellow port. Distal meaning it's at the very end of the catheter. It's the very, very tip. Okay? It's used to measure pulmonary artery pressure. Pulmonary artery pressure is 15 to 26 millimeters per mercury systolic. 5 to 15 millimeters mercury diastolic. Pulmonary artery mean pressure is around 15 millimeters of mercury. Let me get caught up here on my under content lecture. Okay. Now this pulmonary artery pressure, basically shows the right ventricular function and the pulmonary circulation pressure. Okay, the PA diastolic pressure reflects left ventricular pressure. Okay, really what we're looking at is the left ventricular end diastolic pressure. Okay, what I want you to know. Causes of increase of pulmonary artery pressure are left-sided heart failure, mitral stenosis and mitral insufficiency, and pericardial tamponade. All of those can be causes of an increased pulmonary artery pressure. Now, most of the time when we're doing these pressures, we're not looking at one point in time. We're trending these values. We're trying to see, are they going up, are they going down, or they're staying stable, okay? A decrease in the pulmonary artery pressure can be from decreased circulating volume. Okay, let me get that thing. Now, we talked about measuring pulmonary, yes ma'am. Which one? The decrease is basically hypovolemia, decreased circulating volume. The increase basically is left-sided heart failure or changes in the mitral valve. I had a better slide right there. All right. The red port basically is the balloon port. That balloon port is used for two. I need to stand in front of this microphone. The balloon port basically is used for two things. The balloon port is used initially as we insert the swan into the thing. Once we get it into the right atrium, the balloon is blown up, and then that balloon acts like a sail and actually helps pull that catheter through the right ventricle out into the pulmonary vasculature. And then once that balloon reaches a certain area, it actually wedges. It actually causes a blockage in the circulation in there. I'm going to be a few minutes. You want to go ahead and I'll pause for a moment. We're talking about the measurements of pulmonary artery pressure and pulmonary capillary wedge pressure. This is the pulmonary artery here, okay? So I've got my Swan-Ganz catheter laying up here. At the very tip is an opening. Here's the opening of it, okay? I can measure pressure through that opening. When the balloon is down like this, I'm measuring the pressure within this pulmonary artery. Okay? Once that balloon is blown up, I am now measuring everything this way. I'm not measuring anything back from this way, so I'm not measuring right ventricular. All of this goes through and eventually gets up to the left atrium here, okay? And then that left atrium is connected by the valve to the ventricle. We okay there? We follow through that. So basically, what this is measuring is this pressure. When at the very end of diastole, this valve is open. So I can actually measure the pressure here in the left ventricle because this whole system is open from here all the way to there. And that's what a wedge pressure is. A wedge pressure is measuring the pressure indirectly from the left ventricle. And by knowing what's going on in that left ventricle, I can see how well that heart is functioning. That's really what this pulmonary artery is about. Now, I cannot leave this up for very long periods of time. If I leave that balloon up, I'm occluding the blood flow going through, and I can cause a necrosis of that section of the lung. So I have to be very careful when I'm blowing that balloon up, how long I leave that balloon up, how long I leave it wedged. So it's very important. We do the wedges about every 2 hours, is what the physician, 2-4 hours. Some places only allow physicians to do them because there's problems that can occur from it. Some places let especially trained critical care nurses do that. So that's going to depend on your facility. But you've got to you'll measure those wedge pressures. Again, we're not looking at a single reading. We're trending those readings. Are we seeing that wedge pressure going up, which may indicate that this patient's going into left heart failure? Or have we been in left heart failure and we're seeing these pressures trending down so things are getting better? That's what we're looking at with that wedge pressure per se. Again, not trying to make you critical care nurses right off, but I want you to understand when you go into CVICU or go into someplace, you understand what they're doing with that. The temperature of pigtail we talked about is this one. Again, that just measures core temperature. It's also necessary as we do the cardiac output on these patients. There are some new ones that actually do continuous cardiac output monitoring. I haven't had the opportunity to work with one of those, and I would love to work with one of those and see how it works. The setup is very similar to what we looked at with the arterial line, and that basically you have a pressure bag, you have tubing that is attached to it. Do me a favor and don't open this one up. I'm just going to have to run this one, and that's kind of what the tubing looks like in the package. I'll have some for you to work for in there. But basically, it's inserted, the catheter is inserted through a central line. The central line then basically you thread it through and you're hooked up to the transducers. Typically you're hooking up that blue port and the yellow port to transducers. Those are the ones I'm going to be measuring pressures from. The white port is typically attached to an IV system of some sort to give fluids through them. One of the critical care units at CCU actually has this big pump. You can run like 5 different fluids through it at one time if they're compatible. So those would actually go into that. We actually use what we call the manifold, and you'll see that on the guy in anesthesia inserting. It's a piece of plastic this long that has stopcocks on it, so you can put different fluids in it and manage the different fluids from there. You have to have a pressure bag. You have to have a monitor. All of that is necessary in actually doing this pulmonary monitoring system. You got to have that monitor, the transducers, and the recorder. Now, your responsibility as a nurse is not putting the swan in. It's not floating the swan in. The video that I posted for you does a very good job of showing what that nurse is responsible for. The physician, let me borrow it just a moment from you. Okay. The physician's going to have this in, and they're going to hand this in off to you as the nurse. Okay. So I'm up here getting ready to put this in, and I'm going to tell you, go ahead and connect up these tubes to your transducers, and I'm going to say, flush the distal port. And I'm going to watch and make sure that the fluid comes out. I'm going to say, blow up the balloon. I'm going to blow up the balloon and make sure the balloon is up. I'm going to say, flush the proximal port, which is the blue port. I'm going to watch for what's coming in. Flush the infusion port. I'm going to watch for it coming out. That way I have this now primed, and I'm ready to insert it. As I put this in, I'm watching all this hooked up to the transducers, and I can ask these waveforms. So I'm now pushing this in through the port I'm inserting. Once I get to the waveform to the right atrium, I say blow up the balloon. what we're going to be looking at. That's the nurse's responsibility. Your responsibility will be setting up those transducers, setting up the monitor, having everything set out for that physician to do this in a sterile type process. You'll level the transducers to the patient. Those transducers have to be leveled to the phlebostatic axis. The phlebostatic axis basically is a point on the chest, okay, where it is mid-axillary line, fourth intercostal space, and that's where you're going to level to. And you're going to level the stopcocks on the transducers to that level. And this kind of shows, and I forgot to bring down my homemade one that I've used before. It's nothing more than a yardstick with a string level on it. That's all it really is. They've got these fancy ones. That's what I used. That's what I used at Walter Reed, big fancy Army hospital. We used a yardstick with a string level. Works great. But now they've got these nice fancy ones that you can clean real easily. So, you know, it does make more sense that you can clean it for all the bacteria and everything that's there. But that's what that nurse is doing. They're leveling that transducer to the phlebostatic axis so that it's level. Now, you will see different studies showing different things about where you should measure these. Some say you should measure with the patient sitting at 45 degrees. Some say you should measure it with the patient laying flat. Whatever position you have that patient in, you just need to make sure you have the transducers leveled to that phlebostatic axis. Your hospital will have their SOP on how they want that done at that point in time. This is kind of what I was talking about with the insertion of the pulmonary catheter. Basically, when it goes in, they can see it going into the right atrium. You can see these atrium pressures. Then you'll see it go into the right ventricle. You'll see the big waveforms. Then you can see it move out into the pulmonary artery. And then you can see where it wedges. And again, once they get it wedged, a lot of times they'll go ahead and deflate the balloon and kind of pull back a ways and inflate the balloon again. And then what they want to make sure is once they deflate that balloon, it goes back to this waveform. Because if it's this waveform, you're totally occluding that blood flow going to that section of the pulmonary artery, the pulmonary capillary area. So you don't want that to happen. So this is the waveform that should be showing on your monitor the entire time you're monitoring that patient, except when you're wedging that balloon. Your roles, we've talked about this. This is basically, you do have to get informed consent of the patient to do this, so that may be part of your policy. You're going to set up the pressure, you're going to flush all the ports, you're going to establish the phlebostatic axis, and we'll talk about zeroing when we do the lab section, and then you'll assist that physician as necessary. We've kind of talked about this, large vein, all the way through. Complications, infections, bleed back, bleeding at the insertion sites, pulmonary embolisms, air embolisms, pulmonary infarction. You can get rupture of the pulmonary artery. That balloon actually can blow up and do that. And you can also get ventricular dysrhythmias from that catheter being in the right ventricle and bouncing around in there. And that's really all I have on that. That's all I have to say about that. That's enough, right? All right, questions? Yes, ma'am. Purpose of leveling basically has to do with when you're looking at measuring pressures. Remember, if it's at a higher level, the pressures are going to be different. That's basically going to give us the most accurate reading of the pressures. The phlebostatic axis when you're measuring it. And typically what nurses tend to do, we'll tend to find that area and we'll draw a dot there so that everybody knows to measure from that same area. You can't really tape it down because basically it's the transducers are on the IV pole over here, and that's the reason you use that level to make sure it's level. You use that bubble to see. Okay. Yes, ma'am. No, the patient's not always unconscious. Well, again, they may move. Again, if I'm doing that, when I'm doing that wedge pressure, I want to make sure it's at that area. But I'm consistently trying to keep it at that area. The patients are going to move. You're never going to keep them exactly in the same spot. No. Again, we're looking at trends. Technically, go ahead. Right. What he said was basically, if I'm doing my 2-hour reading, say this is my time to document that, I'm going to make sure all this is in place. I'm going to make sure it's leveled, everything. First thing in the morning, we always go through and zero the systems. And that basically means opening it up to atmospheric air and not counting for atmospheric pressures. So don't worry about it. Just know you zero the system. And then you'll level it, and then you do your readings. And then through the day, when you do your readings, you'll make sure it's leveled. And you can tell if that patient's moving. You'll see the values go up and down, and you'll check on your patient. Remember, don't treat the machine. Don't treat those readings. Treat your patient. Questions? All right, take a short break, and we'll come back and see if we can't hit up on those nice little children.